Welcome. I'm Scott Goetzinger, and today we'll be going over how Hipkins can improve their orthopedic operations. Hipkins Hospital should adopt a pooled OR operating plan with optimized arrival times, corrected staff ratios, and updated EVS cleaning procedures. All this will increase surgeon throughput to 18 surgeries per day, reducing patient flow times by almost 1 hour and improving daily profit by over 2,000%. All while maintaining revised burnout thresholds for personnel that are safe and efficient. Hifkins requested our services to optimize their orthopedic operations with the goals of maximizing profits while increasing the number of patients served, improving the patient experience, and reaching sustainable clinician workload. The current system consists of two patient tracks, Track A and Track B, each with one dedicated surgeon, one dedicated anesthesiologist, and two operating rooms. These clinical teams also share additional resources, including registrars at the front end and EVS cleaning crews at the back end. With this setup, the OR behaves like a classic job shop, where each job, or in this case, each surgery, is highly customized for the patient, requires a highly specialized medical team, and can only accommodate one patient at a time per OR. And because of this nature, they're extremely sensitive to delays and variability. Just by looking at the current process flow, we can easily spot the two areas that have the most impact on the system's potential for improvement. The actual procedure itself, where most of the time is dedicated, and room turnovers, which can delay procedure turnovers if the rooms are not ready. We were able to verify those assumptions with simulation models that allowed us to recreate how Hipkins' orthopedic service actually functions today. These simulations allowed us to measure daily throughput, patient flow times, resource utilization, and financial performance across multiple days, which helped us to locate bottlenecks and understand how the job shop nature shapes the system's performance. Taken together, the simulation data shows long and inconsistent flow times for patients as they move through the system, an overburdened anesthesia team, an inefficient EVS cleaning process that causes backups, and inconsistent profitability, all of which indicate clear opportunities for improvement. The first of which is to redraw the utilization burnout rate, which is currently set at 50%. In typical clinical operations, and especially in a job shop environment like an OR, a 50% threshold is far too conservative. Studies show that highly trained specialists and support staff typically work efficiently at higher utilization levels without experiencing burnout. With that, our recommendation, backed by research, is for a more efficient utilization target of 80 to 85%, which will allow you to maximize your staffing resources without burning them out. Once we realign the utilization thresholds, we use simulations to test how changes to different areas of the system could get us to our goals of generating higher throughput, shorter flow times, and better profit, all without exceeding those revised burnout thresholds. We start with the current baseline from scenario 1, making some small changes in scenario 2 by increasing the number of ORs, adding CRNA and PA support staff, and eliminating the two-track system to pool our resources across ORs. Then we build off scenario 2 by reducing arrival times, adding more support staff, and improving EVS cleaning procedures in scenario 3. What we see from these changes when we look at the average results in our simulation runs is impressive. In scenario 2, we start to see how those small changes can make a big impact, where we introduce pooling and more support staff into the system. These changes redistributed workloads across all medical providers, and they start to address our anesthesiologist bottleneck by reducing flow times, increasing throughput, and all without increasing the workload to the providers. Scenario 3 is where we see the most significant improvements, where by decreasing arrival times, we feed a starving system. By adding more CRNAs, we further break up the anesthesiologist bottleneck, and by implementing AVS process improvements, we reduce backups caused by ORs that might not be ready in time for new patients. All that adds up. Starting with profit, we see over a 2,000% increase from about $1,000 a day to $23,000 in our optimized scenario. Daily throughputs of patients jumps significantly, where we go from 4 to 5 surgeries per surgeon per day to as many as 9. Flow times drop as well by almost an hour. And we also see utilization levels start to level out to healthier ranges. To better understand these proposed changes and their potential impacts, we can use the 4 lenses of operations management. First, with utilization. One of the clearest insights is that correcting utilization for anesthesiologists and surgeons directly increase patient throughput by removing one of the primary bottlenecks in the system. Second, with pooling, in scenario 2, we see that the use of pooled ORs with the addition of support staff dramatically reduce wait times because it means that surgeons and anesthesiologists are no longer constrained to a fixed room. Where pooling now allows them the flexibility to move where they're needed, which helps to gain efficiencies across the system, which the variance lens helps to explain. As variability is lowered, everything becomes smoother and more efficient, which leads to less delays, faster times through the system, more patients served, and no patients are being kicked the next day. Finally, all this adds up to the psychology of the situation for both the patients and the providers. For the patients, the situation has dramatically gotten better because the process is at least 1 hour faster and no one is being pushed to the next day, which reduces their anxieties around waiting and makes for a more reassuring journey through the care system. For providers, increased utilization means they'll have better opportunities to sharpen their skills and less of their day is spent waiting around. And reduced variances mean there will be less stress as the process runs smoothly and with less delays. Taken together, these lenses confirm that our recommended model delivers improvements to the operations, finances, and experiences. The last important design decision we considered relates to diversity, equity, and inclusion. We initially evaluated whether separating patients into different tracks based on their BMI might create efficiencies, as different BMI levels can be completed at different speeds. However, we chose not to move forward with that approach because while it might have advantages, we feel that dividing patients based on physical characteristics, especially ones associated with bias and stigma, would conflict with core DEI principles. In conclusion, the analysis confirms that Hipkins can substantially improve financial, operational, and well-being outcomes by implementing a pooled OR system supported by balanced staffing and reduced arrival time spacing, with the addition of improvements to the EVS cleaning processes. Pooled ORs eliminate idle time, corrected staffing ratios remove the anesthesia bottleneck, tighter arrival times increase surgeon throughput, and improved cleaning processes prevent backups by ensuring rooms are always ready. Together, these changes reduce average patient flow by over an hour, double the number of patients seen, and raise daily profits to almost $24,000, far exceeding the current system performance.